And warn her about the danger signs. You have to tell her about edema, inflammatory arthritis, joint aches, etc. Monitor through anti-double-stranded DNA, and the quality and the values should be quantitative values of anti-double-stranded DNA. Complement levels should also be monitored regularly. If the patient has skin-limited disease, then the mainstay of treatment remains topical steroid, and the potency and formulation depends upon the site of usage. However, if your patient is not responding, you can add tacrolimus and pyrrolidinous. Intralesional steroids can be used very safely, and in extensive disease, you can start HCQ in pregnancy too. I won't go into the details of antiphospholipid syndrome. However, it's a rare thing, and our obstetricians are well trained to look after it. What happens is that there is basically increased risk of vascular thrombosis, and the patient has positive antiphospholipid antibodies in the blood and anti-Rho antibodies. Treatment remains prophylactic low molecular heparin and low dose aspirin, and the dosages are usually titrated by the gynecologist at consultation. Important signs. How are you going to differentiate lupus nephritis from pregnancy-induced hypertension or preeclampsia? Hypertension can occur, preeclampsia occurs after 20 weeks of gestation. However, in patients of SLE, hypertension can be noticed anytime. Similarly, platelets are low to normal in normal pregnant female, which remains the same. The red points are highlighting the differences. Complement level will be low in SLE and high in normal pregnancy. Similarly, uric acid increases in preeclampsia but remains normal in lupus nephritis. 24 hours urinary calcium remains low in lupus nephritis, and urinary sediment is active in lupus nephritis and inactive in preeclampsia. One important thing, the lupus nephritis in pregnancy will respond only to steroids, whereas preeclampsia will respond to antihypertensive drugs. Now coming to the most important point, steroids in pregnancy. If I would say that steroids still remain the safest treatment of autoimmune disorders in pregnancy, I won't be wrong. The two important points are the choice of steroid. As we all know, there are different groups of steroids. Prednisone and methylprednisone, they do not cross the placental barrier very much. So, अगर आपने mother को steroid देना है, you want the effects on the mother, you should prescribe prednisone and methylprednisone. Betamethasone and dexamethasone will cross the placental barrier, and they will affect the baby more, as the fetus more as compared to the mother. अगर आपने fetus को steroid देना है, जैसे कि maturation of lungs के लिए दिया जाता है, so then you use dexamethasone or betamethasone. So remember, prednisone is for the mother, and betamethasone and dexamethasone is for the fetus. If your patient of LD is on steroids before she conceives, continue the steroids throughout the pregnancy. There is only very little risk of cleft palate, and it is mentioned in literature. However, low doses remain safe. At the time of delivery or cesarean section, you need to increase the steroids a little, and then you can later on taper them down. If your patient gets a flare-up of lupus erythematosus during pregnancy, previously she was asymptomatic and now she's developing symptoms, start her on steroid. Safe dose to start is between 30 to 40 milligrams of oral prednisolone daily, and then you continue this throughout the pregnancy. Now coming to the other disease-modifying drugs. Azathioprine remains the safest disease-modifying drug for all autoimmune disorders in pregnancy. If your patient is on azathioprine before she conceives, continue with the same dosage without any adverse effects during the pregnancy. Even if you start it during pregnancy, inshallah, there won't be many side effects. Similarly, HCQ can be safely continued throughout the pregnancy. HCQ is a beautiful drug. It is very safe in pregnant females, and it has very little fetal side effects. So, steroids plus a combination of azathioprine and HCQ remains the mainstream of treatment for all autoimmune disorders during pregnancy. Mycophenolate mofetil is contraindicated, and other safe drugs would be tacrolimus, cyclosporins, and role of biologics is not yet established. The drugs that are totally contraindicated are methotrexate because of its teratogenicity, mycophenolate mofetil, it also causes fetal malformation. It has to be stopped at least 3 months before your patient conceives. Similarly, cyclophosphamide is supposed to cause fetal malformations. You stop it 6 months before your patient conceives. And safe drugs during breastfeeding would be aspirin, low-dose oral steroids, and HCG. With this, I come to the end of my presentation. So let's sum it up. What you have to do is, pregnancy in the setting of SME will remain a high-risk pregnancy for the obstetrician and for the treating physician. Multidisciplinary approach is required, and as a basic treating physician, you have to be actively involved in that. Active disease is associated with adverse maternal and fetal outcomes, and pregnancy should be planned in all patients with autoimmune disorders. However, an unplanned pregnancy can also be very beautifully managed throughout the period of time if your patient cooperates with you and you properly educate your patient. Thank you very much.